So I have this task today, and perhaps in terms of imaging, now you're imaging your lunch, but just be patient. I will try to keep this short to stay on track. My conflicts of interest, and I would just like to mention that part of our research is supported by a company who's active within the field of imaging, bedside imaging, but it's nothing else. So in terms of imaging techniques to guide mechanical ventilation, clearly, I mean, you can set up just one course itself on the imaging of respiratory system. What I've tried to do is to stick with the title and to speak about how imaging techniques can really provide a guidance to mechanical ventilation. And although it's not the very best approach to split arguments based on the techniques, but more based on the aims, I found this way to be a little bit more clear. But I think this is a general principle. Whenever we have a technique, we have to start from the question and look for the technique that can answer our question rather than the other way around. They just brought me this very cool machine, so let's think about a question to use this machine. But so you will forgive me if I go the other way around. So CT scan is really part of the history of ARDS and mechanical ventilation. CT scan led to the revolution of our view on ARDS, so with the introduction of the concept in the 80s of the baby lung that tells us the fact that the lung is not stiff per se, but that the lung in patients with ARDS is stiff because it is small, and the smaller is the size of the baby lung, the more stiff it is. But I still think that CT scan in ARDS, and I would say generally speaking in the evaluation of the respiratory system, is our benchmark. It has a very high anatomical resolution. It is able to detect heterogeneity, so as opposed to one plateau pressure number, one driving pressure, one arterial blood gas, it can really give us the feeling that the lung is different, and anything we do with our mechanical ventilation will reflect differently according to the level of the aeration of the lung. This is in general the advantage of the imaging technique, and it also allows quantification of the abnormalities which we see on the lungs. So what are the, so as I said, CT scan is nowadays the benchmark which is used in many research studies, and it stays as a solid reference. So as I say, I would like to focus a little bit more on, can this be used to guide mechanical ventilation? I would speak about two approaches mainly, just an overview. I think the first approach is to use the CT scan in its more quantitative features. So this is one of the studies that was published by the group of Gattinoni, where they basically performed CT scan at different levels of airway pressure, 5 and 45 centimeters of water, and in each patient they have assessed the so-called potential for lung recruitment, so the amount of lung which can be reopened by applying a high pressure in the airways. And indeed what they have shown is that there is a large spectrum concerning the amount of lung which can be reopened by positive pressure. So in some lungs there is no reopening. A lot of patients reopen up between 5 and 10% of the lung, but it can be up to 40% of the lung weight which opens up when a high positive pressure is applied. So this study was just descriptive, was like a snapshot of the situation of the patients with ARDS. But we can imagine, and I know that some centers do this, to use CT scan before setting PEEP and the use of recruitment maneuver to decide whether the patient has a lower potential for lung recruitment, and so in such patients perhaps it's wiser to use a lower PEEP, and it would make sense to use higher PEEP and recruitment maneuver in those patients in whom we know that the lung has some recruitment potential. So this requires, of course, first of all, the transfer to the CT scan and the use of at least 2 levels of pressure to assess the presence of or the amount of lung which can be recruited. Another approach has been, there's thousands of papers on CT scan and ARDS, so there are many approaches that have proposed it, but just as 2 examples, I brought these 2. So the other example I bring you is the one proposed in this paper by the group of Jean-Michel Constantin, who gave a talk this morning, and basically they have collected CT scans from a few hundred about of patients with ARDS, and they have divided these patients in 2 groups, one with a more focal ARDS, as you see here, so affecting just some specific region of the lungs, and to some more non-focal ARDS patterns. And what they found is that these 2 groups had different concentration of RAGE, which is an inflammatory mediator in the, or more than an inflammatory mediator, a marker of lung injury. So a different concentration in RAGE, and also these 2 groups had a quite different mortality at day 28 and day 90, being non-focal ARDS associated with a higher mortality. And so this group is now proposing an approach, and again the algorithm is relatively complex, and I'm not going into detail, but it's to show you that in principle some groups are proposing that CT scan should really be one of the first assessment to be performed in patients with ARDS, so that then these patients can be treated according to their CT scan phenotypes with, for example, early prone positioning versus early recruitment maneuver. And they have designed this very elegant study to test these hypotheses and whether this hypothesis can lead to a benefit in patients' outcome. And to summarize on CT scan, I would say that this is kind of the approach which we normally follow. We don't have a CT scan in all patients. We just try to follow what is the normal, I would say, the bedside feasible diagnostic workup, so bronchoalveolar lavage, measurement of respiratory mechanics, optimization of the bedside, optimization of ventilatory settings at the bedside, but then we also share this, I would say, policy that if the status does not improve, or if we are still missing a diagnosis after, I would say, a regular diagnostic workup, we go for a CT scan quite early in the course of the disease. This is, by the way, an interesting paper I recommend you to read, which provides you a nice overview on the diagnostic workup for ARDS overall. And indeed, this was the case also for the patients enrolled in the LungSafe study. This is a secondary analysis of our study where Nicolas Deprost have analyzed the data, and he has shown that patients with no risk factors identified for ARDS underwent more frequently to a CT scan in about 32% of cases. So this emphasizes the fact that CT scan does have also a role, a clear role in clarifying diagnostic doubts we might have. EIT. going to the next topic, EIT, I would spend a few words on the, let's say, methods on how the technique works. And just because it's something that has been released on the market quite recently and it's not that common. EIT is based on the application of a small current of a small alternating current between two electrodes, and there is a belt around the patient that is measuring the potential generated by this current. So this is the belt attached, surrounding the chest of the patient with all the electrodes attached. And basically, the machine injects the current through a couple of electrodes and reads the potential, the difference of potential among all the other couples. And then the injection point is moved, and again, this operation is performed. I will not show you the whole combination, but this is happening very, very fast. So about 20 to 50 times a second. So the rate of acquisition is about is between 20 and 50 hertz. And this is what you get. You get basically a real-time image of ventilation. This should go on, okay. A real-time imaging of the air entering within the lungs and leaving the lungs. And this is because air has a very high impedance, which is, to make it simple, a very high resistance to electricity. And so the machine is able to detect how much and where the air is entering the lungs, okay? So as you see, EIT has a relatively low spatial resolution, but it has a very high temporal resolution. So it's really something that is available online. Sometimes EIT is compared or is assimilated to CT scan. And I think this is a bit misleading, because CT scan looks at aeration, so presence of air. EIT does not look at the presence of air by itself, it's looking at ventilation, so air moving in and out of the lungs. So here you clearly see that these two regions of interest do not have any ventilation. So ROI 1 and 3 are flat. There is no ventilation going on in the right lung. But this could be due to totally different situation. You can have atelectasis, you can have blood, or you can even have a massive pneumothorax. So EIT is able to see ventilation, not aeration, at the bedside. So why is EIT important? Not just to make fancy movies, but to quantitate, to measure, and to translate into a number the ventilation, the amount of ventilation which is entering the different lung regions. So let's say that our tidal volume is 100%. We can measure how much tidal volume is going into the most ventral regions, 10%, in the middle to ventral, middle to dorsal, and in the dorsal region. How can this be used in the clinical practice? What now? What if we know that we have 7% of ventilation in the dorsal region? Well, this is very important because it's an important readout of our therapeutic strategies. For example, here Dr. Cinnella compared two ventilator strategies, open lung approach before and after open lung approach. So PEEP was very different and oxygenation was very different. And what they have shown with EIT is that, for example, the use of a higher PEEP led to an increased ventilation of the dorsal region, which went from 11 to 20%. So we are not just looking at one number of compliance, one value of PF, but we are looking at what is happening in the different lung region. Another possibility is to monitor by the use of EIT what you see here, which is the end expiratory lung volume. So you cannot measure this in absolute terms. You cannot have a number, like if you measure it with nitrogen wash in and wash out. But what you do is you can observe the changes above a given baseline. So, for example, here Tommaso Mauri has shown that if you give periodic sighs, these big breaths delivered by the ventilator to the patient, the end expiratory lung volume is increasing, suggesting indeed that there is some recruitment going on in these lungs. So we have tried to move this concept and to use EIT not just as a readout of what we were doing by mechanical ventilation. So I increase PEEP and I measure that I have recruitment, but to use EIT as a guide, to guide our PEEP setting by the use of this imaging technique. And what we have done is to measure this change in end expiratory lung volume following a PEEP change. Now, what's the problem with that? Is that always when you increase PEEP, your end expiratory lung volume will increase. Not necessarily because of recruitment, just because of distension of alveoli which are already open. So how can we dissect these two phenomena, alveolar distension and recruitment? And I don't want to make it too long. There are several approaches you can follow. We have decided to follow one principle, which is the fact that alveoli can be opened by high airway pressure, but then stay open as far as PEEP is adequately set. So the closing pressure of the alveoli is much lower than the opening pressure. So to make a long story short, this is what we did. We started from a ventilation at a given PEEP level. We gave a recruitment maneuver, and of course, you see here that there is some recruitment going on, because now the end expiratory lung volume has increased. But this graph tells us that the level of PEEP we had set was not enough to maintain recruitment, because as you see, this time, sorry for the scale missing, is 10 minutes. So you see that by 10 minutes we lost all the recruitment we had achieved. So what we did was to give another recruitment maneuver and to increase PEEP by 2 centimeters of water, and in this case you see that the PEEP is adequate to maintain alveolar stability. We have tested the feasibility of this approach in this study on hypoxemic respiratory failure. Not all patients had ARDS, and we started from the PEEP set according to the ARDS network, and we kept increasing PEEP until we saw that there was no more loss of recruitment following the recruitment maneuver. So here the PEEP is stable. The end expiratory lung volume is stable. This approach was feasible in most of the patients, in 14 out of 16 patients. The PEEP which we set by EIT was higher than the PEEP set by NIH, but there was not really a correlation between these values, and we had to change on average PEEP 2 times to achieve the final level. What we have also shown is that there is a quite good correlation between the gain in volume and the gain in compliance. So compliance could be a bedside indicator of recruitment, but as you see, the signal is quite small. It's just within 10 points of compliance. And in our patients, it didn't seem that the oxygenation improvement had a real correlation with recruitment. Of course, by the technique, it is also possible to image the amount of tissue which is going over this, which is undergoing overdistension, because we always pay a price. Nothing comes for free. You recruit the lung, but you also overdistend the ventral regions. And finally, a few words on ultrasound. I will skip the ultrasound on the lung parenchyma. I think it's very interesting to focus on this aspect, on this other aspect, just not to be too much focused on just the lung, but also on what is surrounding the lung, which is the possibility to image the patient diaphragm by means of ultrasound. This is also a nice paper I suggest you to read, and basically we can measure 3 parameters by ultrasound on the diaphragm. The first one is diaphragmatic thickness, okay? So this is done by a linear probe just above the liver, and you see here the pleura and the peritoneum as 2 hyperechoic lines, and down here is the liver, and you can measure very, very well the diaphragmatic thickness, which, as I will show you, gives you an idea of the general trophism of the diaphragm, the size of the diaphragm, basically. Here, you switch to M mode, so now the x-axis becomes time, and as you see, you can notice that during respiratory effort, diaphragm becomes thicker, exactly like any other muscle. When we make an effort, the muscle becomes thicker. And so does the diaphragm. And we can measure this. And finally, we can measure by a curve probe, we can measure the excursion of the diaphragm. So the actual movement that the diaphragm is undergoing to. So why is it important to measure the thickness? Which information can we gain from the thickness itself? This is something that it's really emerging on the field, and I think this is mainly thanks to the work of my friend Ewan Golliger from Toronto, who's really a brilliant researcher. And he has shown that if the thickness of the diaphragm stays constant over the duration of the ICU days, these patients in green do much better in terms of clinical outcome than these patients in red, in whom the diaphragm starts to lose mass and become thinner and thinner. So this information, this data gives you, I would say, an overview of the health of the diaphragm, on the status of diaphragmatic health. On the other side, you can gain some information from thickening. And as I say, thickening is an expression of muscle contraction. So the highest the thickening fraction, okay, which is exactly the percentage by which the diaphragm becomes thicker, the greatest is the effort that the diaphragm is generating, both in terms of pressure here and in terms of electrical activity. Clearly, there is some dispersion because there are many other factors in place, but the idea here is that you can have a glimpse at the bedside on how hard the diaphragm of your patient is working. So in conclusion, as I promised, I've spared a few minutes. I think that imaging techniques provided us unique data that allow us now to understand better ARDS, and in general, I would say mechanical ventilation, particularly, as I said, because of their ability to capture heterogeneity. CT scan is our reference, is our benchmark, and I really think that if we need to have a solid reference. This is still and will still be our solid reference for many, many years. But at the same time, more and more bedside radiation-free, cheaper techniques are emerging, such as ultrasound and DIT. And particularly, as I said, I think in the next years, we will finally have a tool to assess the diaphragm, which so far is a muscle which is crucial in our patients, but which we have very, very, very limited information on. And I think ultrasound will be, I cannot say the magic bullet, but certainly a very valuable tool in assessing this muscle. Having said that, I thank you very much for your attention. Thank you.